Yeah, I'm so sorry for the interruption. I'll continue. So, am I audible?
Yes, sir, you're audible.
So, he educates other dentists on aesthetic dentistry through webinars with 300 plus registered participants. He is a life member of IAACD, Indian Academy of Aesthetic and Cosmetic Dentistry. He has done various presentations in national and international conferences, and he was honored to receive first prize for paper poster presentation, that is paper presentation in the ADAI conference. He also have a keen interest in photography, so he loves dental photography in his work hours and wildlife photography, which we can learn from him. So, welcome, Dr. Srujan. Please go ahead. Over to you.
Thank you so much, sir. Thank you so much for this introduction. First of all, I want to apologize for everyone for the miscommunication and delay in today's webinar, but we'll just start straight up. I've shared the screen and let's just go ahead and okay. So, like sir said, just 1 minute. Yeah. So, like sir said, today's topic of webinar is Art of Direct Anterior Composites. It's going to be a short and sweet webinar, and we are going to cover a few topics. Uh, Those who has already introduced me. My name is Dr. Srujan, and I've completed my BDS from Loni and my fellowship in aesthetics from Savita Dental College, Chennai. So these are the topics which we are going to cover today. It includes the basics of composites. Then we'll learn a little bit about shade selection, cavity and bevel preparation for anterior teeth, and finally we'll end with surface treatment. So this slide I have in every webinar of mine. I believe the mantra to achieve excellence, no matter in what field we are, there are three rules or three steps you need to ace at. And three steps are understanding what the field is, why your field is so important, why is it so beautiful that you want to pursue it, and third is how do we do it the right way. And that is exactly the approach which we are going to follow today. We're going to understand what composites are. I'll try to share all the basics about composites with you guys. We are going to understand why do we do it, and then we are going to see how do we do the correct shade selection, beveling, and then finally surface treatment. So composites is basically a tooth colored resin based material which is used in restorative dentistry, like we all know. The composition of it is resin matrix majorly and inorganic filler particles, which is usually glass or quartz. Now, based on the size of filler particles, composites are divided or distinguished, classified as macrofilled, microfilled, and hybrid. Macrofilled composites are basically the composites which have filler particles of greater diameter or greater size. So they are going to exhibit good strength, but they're going to be a little uh, poor or a little bad with aesthetics because it is not going to be very polishable as the filler particle size is larger. On the other hand, microfilled composites are going to be highly aesthetic, but are going to show a little bit of lower strength, mechanical or tensile, and everything else. Whereas hybrid, which has gotten more famous recently, is something which is a sweet spot between both of macrofilled and microfilled composites. Now, we all talk about curing, right? But let's understand what curing really is and how it happens. So, Curing or polymerization is the chemical reaction in which the monomer molecules in the composite resin join to form a rigid polymer network, allowing the material to set and harden. Now, the soft composite that we have in our syringes is basically, uh, a group of monomer molecules together. When we expose the curing light at the specific wavelength, usually 450, 480, 520, 560 nanometers, what happens is it initiates the polymerization reaction. So the individual monomer molecules slowly start converting into polymer networks, and that is what makes it rigid. So there are two steps. First is the free radical addition polymerization, and second is step growth polymerization. We are not going to go in details of that. The bottom line is when you expose the composite to a visible light of a specific nanometer, it is going to get cured. The catch is you need to expose it for a specific amount of time and with a specific uh, intensity. There are different intensities, so I would suggest you get a curing light with a minimum curing intensity of 800 to 1000 milliwatts per centimeter square. Now, we all get this very common question from patients in our clinics that डॉक्टर ये composite आप भर तो रहे हो बट ये कितना दिन टिकेगा, ये लाइफ टाइम टिकेगा क्या? I want a lifetime solution. And there is only one correct answer for this question. If you want anything to stay for your lifetime in your mouth, just stop eating. And everything is going to be picture perfect, right? So basically, composite is a plastic material and regular maintenance is necessary. Obviously, it is going to wear out over time. Something which God has given, the natural enamel, the hardest substance, if that can tear off, if that can wear off, composite is merely just probably 1 or 2% as hard as enamel. So we need to tell the patient that it is going to wear off, maybe just debond or something might happen. I cannot guarantee you unless you stop eating, of course. So instead of doing just fake promises and all, it's better to just be clear upfront, telling your patient that you'll have to come for regular maintenance, probably every 3 months for the first year, and then every 6 months after that. And other than that, other than maintenance, there are a few more points which we need to look out for when we are planning for a successful composite case. By successful, I mean a long lasting and equally aesthetic and functional case. So the first point is case selection, technique, and material. Now, the case selection is very important to understand because it won't stay for very long for obvious reasons, right? Second is the technique. Isolation plays a very important role. We do not have these topics planned today, but I am just going to give you an overview of all of these 3 points because it is very important to know that. And the third is material. There are shades, a lot of it is there, and we just don't know sometimes what do we go for. So we just go ahead and choose the one which is budget friendly, or maybe something which our dealer is suggesting us to get, right? We are going to talk more about composite materials soon, so this is one point I want you to hold on to. We need to choose for the best material if you want the best results only. Okay, so let's understand why do we do composite restorations, or why do I like doing composite restorations. First, it's minimally invasive. We know this, this dentistry, the modern dentistry is focused towards being as conservative as possible. We just want to preserve maximum amount of tooth structure. We don't want any destruction. We don't want any removal. And composite restoration is going to 100% adhere, right? So it's a minimally invasive procedure. It's a single visit procedure. You can complete the entire restoration on the first visit itself. Of course, you can call the patient again for finishing and polishing, but the whole point being it is quick, right? Third point, it is less expensive, which is something which patients love. And maybe we also love because we get good margin in it, right? We have no lab charges. It's nothing else. It's that's why the second last point. It's you're the master of the technique. You are going to be the creator of the entire procedure. It's no lab in between. There are no two minds. It's all you. So you are entirely in control. You can do a good job. And you, if you do a bad job, you don't have anyone to blame to. One of my favorite mentors once told me, if you think that you're good at dentistry, or if anyone thinks you're good at dentistry, just do composite once. Composites are going to humble you. It's not easy. It's definitely not easy, but it's not impossible either. So we need to understand the right technique. And the most important point is we need to practice it regularly. Okay. Another point which I love about direct composite restorations is it's easy to repair. If you take a crown, a veneer, onlay or inlay, if it is chipped off, you just probably have to remove the entire restoration, entire crown, and you have to place a new one, right? On the other hand, if patient comes that one of the incisal corners just got chipped off, doctor, while I was eating something hard, what are you going to do? Do you have to remove the entire restoration? Obviously not. You can just etch, bond again, probably give a small bevel over there, and just complete the restoration. That's it. You're done. And because of all of this, it is super, super satisfying. If you get a good anterior composite restoration result, trust me, you're going to have a very good sleep that night. It is the best feeling in the world. So, if you are doing something entirely by yourself, and if it turns out to be good, you are going to be very happy with yourself, and the patient is going to be happy with you. So, it's a win for you, right? So, but for this, obviously, we need to know the right technique. So, let's dig right into the technique part of it. And the first thing we are going to learn is obviously shade selection. Now, shade selection is always the first thing which you have to do during any restorative procedures, anything in dentistry for that matter, right? I'll tell you why. Look at this picture over here. It's a pre-op picture of a patient. I just took the picture and I was like, okay, you know what? I'll just do the rubber dam isolation and we'll go ahead with the shade selection then. I mean, how does it matter? It's still the first step, right? I did the rubber dam isolation. And do you see the white flaky appearance on the rest of the teeth? Basically, due to dehydration, the shade, the general primary shade of the tooth or the entire arch just got more opaque. It just turned out to be a little more whitish. A2 becomes A1, B2 becomes B1, or something like that. So dehydration is going to be one of the biggest challenge you're going to face. And to tackle with that, you need to do the shade selection before you do anything else. As soon as the patient sits on your chair, you do the consultation, you ask the patient to rest for a minute or two. The first picture you take is of the shades. You do a composite shade button technique, which I'm going to talk about soon. But yeah, the point is you have to do the shade selection as the first technique. Now, when we talk about shade, there are three dimensions of color or shade. We've learned this theoretically, right? There's hue, chroma, and value. But uh, at least I never really understood it entirely when I was taught about this in my college in the prosto department. So I try to understand a little bit more about it and why it is so important for us. So here it is. Hue. Hue is basically the color, the family of color, right? Green, yellow, red. These are different hues, different colors. Now let's take a specific hue. For example, red. Now what is chroma? Chroma is the saturation of that hue. It is the saturation of a red. If the hue is red, higher chroma is going to be more saturated version of a red color. Low chroma is going to be a little faded or a less saturated color. And what is value? Value is the brightness of that color. Greater value is going to be bright. Lower value is going to be dark, right? So just to summarize all of this, hue is the color, chroma is the saturation of that color. It is going to make that color more colorful, more vivid, whereas value is the brightness of that color. Okay, I hope we all are on the same page. So moving on, why should we know hue, chroma, and value? Like, how does it matter? Right? We obviously don't need to understand much about hue because there are, fixed hues. For example, A is a reddish brown tint or reddish brown hue or something like that, right? But we need to understand more about chroma and value because that is exactly how our natural teeth are. If you look at any natural tooth, chroma is going to be higher on the cervical third of the tooth and it is going to be lower at the incisal third, whereas value is something which is most of the times just opposite of chroma. A tooth is more brighter at the incisal third and it is little less bright on the cervical third. We all have seen this. And we need to know this because that is how we are going to place our composites. If you are looking at aesthetic restoration, aesthetic direct composite restoration, it cannot be monochromatic for most of the cases. Yeah, you'll have to do detailing. You'll have to add more than one shade, maybe more than one opacity. Coming to which we all always talk about chroma, hue, value, and everything. But there's one topic which we never talk about, and that's opacity. It's something which is very nicely ignored but is equally important as chroma and value is. Let's see why. These are the composite kits which we usually purchase, right? Because we get a very good deal. We get a bonding agent, we get etchant with it, we even get the applicator tips, we get everything to, in a very good price. We are just so happy. We just feel like we have got the best deal. Our dealer just gave us the best deal. We've got all of this. But there's one problem with this. All of these composites are universal shades. They are universal nanohybrid composites. They're suitable for monochromatic restorations, probably for uh, a little older patients who do not have a lot of chroma differentiation or probably at the posterior teeth. They are nanohybrid filler particles. That means they possess lower aesthetics and cannot be used for layering. They come in different shades, but they do not come in different opacities. When we talk about opacities in composites or even in natural tooth, there are four different opacities which we need to have. If we want to replicate something natural, we need to have the material for that. There are four opacities: dentine, body, enamel, and incisal. Dentine is the most opaque material, right? It is going to pass the least amount of light. Body, on the other hand, is opaque but a little more translucent than dentine. A little bit more light can be passed through it. Enamel is going to be translucent. A significant amount of light is going to pass through it compared to dentine and body, whereas incisal, it is going to show the highest translucency. When you look at the composite, for example, transopal, its incisal shade you get from Ivoclar, it shows about 45%. 45% of the light gets passed through it. That's almost half of the light. When you look at the composite, it looks white, but when you take a picture, the picture it appears to be blue. So that's the beauty of incisal composites. It acts according to the light, uh, when the light passes through it at different angles. That is the beauty of hue. That is the beauty of halo effect. That is what we are going to replicate. So the slides, the composites which I showed you right here, right? The kit on the left is by Ivoclar. In the center, it's by Dentsply, and on the right, it's by 3M. And these are good brands, right? So why are they not doing it? Turns out they are. It's just that we are not buying it. The composite shades you see here are by 3M on the left and Ivoclar on the right. You can clearly see right over here, this is dentine shade, this is body, this is enamel, and this is translucent, also called as incisal, exactly what all we want. Right, the difference between both of these composites by 3M is one of it is nano hybrid and this is used for aesthetic restorations. It is going to be useful for polychromatic anterior restorations. The name of it is Filtech Z350, and the ones which we saw here are Filtech Z250. Right, on the other hand, Ivoclar, this is uh, I guess the name of it is something similar, but still the difference is we get dentine shade here. It's a different shade. We get different opacity. Now dentine and body is kind of similar, right? So the whole point about opacities is according to the adjacent natural tooth, we are going to place different opacities and different shades. This is a common anatomy that we can see in any natural young tooth, right? There is a opaque line at the incisal edge, right? Then we have some translucency right over here. We have three mamelons. And how can we distinguish all of this? That this is all because the light gets passed around with uh, that shape. You know, you add translucent composite in this manner, you have prepared mamelons. So you need to layer the tooth according to opacities of the adjacent teeth. Right? This is the entire point of it. Making things easy for you. Wherever you want light to pass from, you add incisal or enamel composite. Wherever you want light to be completely blocked out, for example, somewhere over here, the middle and cervical third, you want a dentine shade. Probably over here at the mamelons where you want a little bit of shading effect or somewhere, some amount of light should be passed and it should not be very vividly seen, Probably you can use body shade over there. There you have it. You have a polychromatic restoration. That's it. Okay, I hope you understood this. So I'm going to tell you what are the composite materials we should have for good aesthetic restorations, right? Dentine shades, A2. It is the most common shade we can use. You take any patient from the Indian population, A2 is going to be the shade which is going to be most commonly used. If it's a young patient, probably A1 or B1 because the teeth are more whitish in appearance. If it's an old patient, a geriatric patient, probably A3 or 3.5. But I would suggest you take dentine shade of A2 and you're good to go with. Body shades, go for A2 and B2. It's good to have B shade too. B shade has a little bit of different hue and it is going to be a little, there's a grayish tint added to it. So it appears a little bit more opaque. It's good to play around with those two shades. When we talk about enamel shades, it's never A2, B2 or A3.5 or something like that. It's always high value and low value translucency because enamel is not going to be about chroma. I'm going to talk about this soon and you'll understand more. For now, I just want you to understand that when you select enamel shades, it's going to be high value or low value. You get HVT, which is high value translucency, and low value translucency by Shofu. Incisal shades I've already talked about. It's transopal, and there are few more incisal shades. But this is the one I regularly use. Transopal. It's by Ivoclar, and it's fantastic. Let's understand how do we do the shade selection now. There are two methods: cross-polarized photo and monochromatic photo. What does the cross-polarized photo do? It eliminates hue and value. So you're focusing on chroma. So you take a cross-polarized picture of composite shade buttons or anything. You're basically going to focus only on the chroma. The differences in brightness or value are going to be gone. So you are going to do dentine shade selection by taking a cross polarized photo, because dentine is equal to chroma. On the other hand, enamel is equal to value, which I spoke about in the earlier slide. That's why for that you're going to take a monochromatic picture, because that is going to eliminate hue and chroma, right? So it's no rocket science. Just understand one thing. For dentine, you need to select the chroma. For enamel, you need to select the value. How do we select chroma? By taking a cross polarized photo. Look at this picture over here. What is happening over here? The picture on the left is a regular picture, and the picture on the right is basically the same picture converted into a cross polarized, a cross polarized photo. So you see the bright spots over here, over here, over here, everything is gone. It's all uniform now. That's the chroma, right? That's the chroma. So you're focusing on the chroma. Does the chroma match? Yes, it does. Okay, moving on. Yeah, so you need to take a cross polarized picture. Also, one more point I quickly want to state over here, that we do not use the shade tabs, the Vita Classic shade tabs for composite selection. I've put this picture for reference, but you are never going to use Vita shade guides, because in this picture itself, you can see that there is a difference in chroma, right? It's exactly like the natural tooth. It's less chromatic over here and highest chroma at the cervical third, right? So the thing is, if this is A2 shade, which part exactly is A2? Is it the incisal part? Is it the middle third? Is it the cervical third? What is it? It's confusing, right? It's not uniform. That's why we are not going to do that. Instead, we are going to make our own shade tabs. What is that? This is a shade tab. You can make one by yourself, or you get uh, you know a personalized shade guide, making instrument which is called Smile Line. It comes from Style Italiano. You can do that. You can make your own shades. This is going to be uniform from the incisal third to the cervical third, right? So this is how you're going to determine the shade for your dentine. And if you don't want to do this, obviously you can just take buttons and place it on the tooth, and then you take a cross polarized picture. That is going to give you enough information on all the dentine shades. Moving on, next I have a fun quick activity for you guys. Can you quickly just count how many colors do we have in this picture? I know this is not very interactive, but I just wanted to show you that this might seem that we know how many colors there are. I first guessed it's probably 7, 8, 9, something around that, right? It's a little easy on this side, but it gets very difficult over here, right? So when we actually convert this picture into a monochromatic picture or a black and white picture, we see how many colors there are. There are 17 different colors in this one picture. And we can clearly see this only when we convert it into a monochromatic picture. So what is happening here? We are focusing on the value. We have eliminated the hue. We have eliminated the chroma, right? So that is exactly what we are going to do to determine our enamel shade. This is the composite button technique I was talking about. You take small buttons of different shades of composite, you place it on the tooth, and you take a black and white picture. So what happens over here? The shade which blends the best, according to brightness. This seems a little more bright to me. This seems a little dull. This is just the this is just the perfect shade that we want, right? So I'm going to go with this. This was A3. This was uh, B2, and this was A2, right? So this is how we are going to do the enamel shade selection. Let's have some quick clinical tips. Chroma is going to be higher on the cervical third of teeth. We have learned this. For the enamel layer, chroma does not matter. Value is important, because enamel focuses on value. You're going to get a lot of brands who are going to market their enamel shades as A1, A2, A3, or many such things. Just do one thing. You take all of those shades, take enamel A1, take enamel B1, take enamel A3. You make a thin layer of 2 mm thickness and you take a black and white picture. And you know what? You're not going to see any difference in any of that. It all depends on the value. So you're going to ask for enamel shade which has more value and one enamel shade which is going to have comparatively lower value. That's it. Now, A2 shade of composite has greater brightness and lower chroma than A3. So that is the difference. Like I said, brightness or value and chroma are inversely proportional. So the difference between A2 and A3 is that A3 is going to be more chromatic. So you're going to use A3 cervically. You will have to use A2 at the middle third, right? I hope we are on the same page. Now, the shade selection is done. What is the next step? Isolation, yes. And after that, we do cavity or bevel preparation. For anterior teeth, it's always bevel preparation. And I'll tell you why. Because, cavity is something which we have learned as it has specific walls, it has cave or surface margin and all of that. Beveling is a term which is more suitable, especially for anterior teeth, because we are just reducing the tooth structure in a specific angle. And why do we do that? Let's learn. So there are three basic types of beveling: primary, secondary, and starburst or tertiary bevel. This is obviously modified over the years now. I took some quick pictures for your demonstration. So this is primary bevel, and this is how you do it. You place the burr 45 degrees to the tooth axis. The main objective of primary beveling is to make the sharp margin blunt. The fracture margin, it should be blunt. We don't want sharp angles anywhere, right? It is a very small bevel, probably 1 or 2 mm, and it is limited only to the fracture margin. Okay, that's it. That is your primary bevel. It's done. This is how it looks like clinically, right? But we have a problem now. If you can see in this picture, we have edge or the bevel margin of the primary bevel, right? How do we do that? That is where the secondary bevel comes in, picture. Secondary bevel is going to involve a lot of your tooth structure, and you're going to place the burr almost parallel to tooth axis. A quick update over here: you don't necessarily have to use burr. You can use a finishing and polishing disc, which I prefer more. And this is also called as the infinity bevel. Why is it called infinity? Because we don't know where it is going to end. That's the beauty of it. This is going to mask the margin of primary bevel with the rest of the tooth surface. So you don't really know where your secondary bevel is ending or where your infinity bevel is ending. That's why it's called infinity bevel. This is roughly how much of secondary bevel I've given. Can you make out where the margin exactly is? Can you pinpoint it? No, right? And in case if you can, or in some cases, probably sometimes you just can, that is where your starburst bevel comes into consideration. It's not a bevel which you have to give every time, but if you feel like if the secondary bevel is seen, probably, then you can just add a zigzag margin at the margin of secondary bevel so that it gets blended even further. We have a zigzag margin now. It's very easy to identify a straight margin, a straight line. But when it's zigzag, when it's not uniform, it's going to be more difficult to pinpoint. Okay, this is where your composite ends. This is where your tooth starts. So this is how we are going to decide if we want to give starburst bevel, yes or no, right? So this is what starburst bevel looks like. It's called starburst because it's like the uh, pointing arrows, pointed arrows towards cervical region, and it is going to be zigzag different depths, and that is how it is going to blend properly. In this case, you can see all the three bevels. The red is primary bevel, which I've made to just blunt the margin. It's not fracture margin over here, but the cavity margin. For the secondary, I've just increased a lot of tooth surface. Another point, another advantage of secondary bevel is we're exposing more enamel rods. making our restoration more predictable because we now have more bonding area, right? And the starburst bevel marked in blue, which is going to help you mask the secondary bevel even further. Now, just notice I've given starburst bevel only at some points. Why is it so? Why did I not give it over here? Because the margin here is already not very uniform, right? Here it's not uniform, so we don't have to do it. It seemed a little straight over here, that's why I gave it here, right? So you are the master of the technique. This is what primary, secondary, and starburst bevel looks like, and this is what you're going to use to do it. I suggest for primary beveling, you can go with a red band burr. Do not use the blue band burrs because they are going to be very harsh on your tooth. There is something called as cantilever, the one on the left, like this, and it is going to give you the perfect bevel, the perfect 45-degree margin, a rounded surface, and it is just beautiful to use. You can get them from high tech, or if you have someone from in contact from USA, you can get it from Comet, Komet. And if you do that, please let me know too, because I also want to get it. Now, the secondary bevel you can give with the help of finishing polishing discs. I prefer using a medium grit, not the coarse one, or you can use Dentsply Enhance Finishing Polishing Kit disc from it, which you can very well use to remove the aprismatic layer of enamel, which is what we are looking to do. And for the tertiary bevel or the starburst bevel, you can use a yellow band, which is fine grit burr, fine grit diamond burr, or you can use a white Dura stone. It's going to be the same. Okay. Now, let us understand why do we do beveling, right? So this is the area which is going to be beveled. And why do I do it? You see the sharp edges over here and here, right? They are going to be gone with the help of primary bevel. We are increasing the bonding surface by making the secondary bevel until here. And we are going to add some starburst bevels at the margin, and it is going to be just, unrecognizable. This is what the bevels look like. All the sharp edges are gone. Do you see any sharp edges over here? It's all smooth, rounded. You see this different depths. That is my starburst bevel. You cannot make out properly where my margin is of my primary bevel or my secondary bevel, as for that matter, right? So this is the whole point. We are going to focus on making our restorations invisible, and in order to do that, we are going to do maximum amount of beveling. We're going to, at the same time, by the way, we are going to preserve the tooth structure as well. We are not going to go very deep. This we are playing only in the enamel, only in the top 0.5 mm, 0.3 mm. That's it. We're not going any deeper than that, right? So that is the whole point of bevel preparation or cavity preparation, whatever you like to call it. But yeah, I hope we all are on the same page. And after we're done with cavity or bevel preparation, we have surface treatment. Now, what is surface treatment? Let us understand that. Surface treatment is the mechanical and or chemical conditioning of the tooth surface, which enhances the adhesion of composite resin by improving the micromechanical retention and chemical bonding. सीधा सीधा एकदम easy भाषा में, it is something which makes your tooth more bondable. Your composite is going to stick easily. And when it sticks, it is going to stay like that for longer duration. That is surface treatment. Let us understand the technical part of it. We all know the two methods of surface treatment we do. It's etching and bonding. Let us dive a little deeper into this. Etching, it is done with the help of 35 to 37% OPA, which is orthophosphoric acid. Enamel, we do it for 30 to 35 seconds, and dentine only to 10 to 15 seconds. Why? Because enamel is a little more inorganic. It's not going to be very sensitive, so you can etch it for a little longer time. But dentine, it's going to be sensitive very soon. So you don't want to over etch because that is going to cause sensitivity to the patients, intraoperative as well as post-operative. You have to avoid that. That's why there's something called a selective etching technique where you only etch the enamel. You don't etch the dentine at all. It's not necessary, right? So why do we do etching? To remove the smear layer. Like I said, we are giving an infinity bevel. Even we are not going to, easily understand where our margin ends. So we need to etch the entire tooth surface so that we remove the smear layer from everywhere, because we don't know where our composite margin is going to be. It might happen that your infinity bevel stops somewhere before your composite margin ends. So do you understand? Some area which you never even beveled is the area where your composite is already placed. Now imagine if you do not condition that area, what is going to happen? Marginal leakage is going to start from there. Your entire restoration might fail, right? So you're going to remove the smear layer. You have to, uh, etch almost the entire tooth. Now, second point is to create microporosities. They are small voids or holes on the tooth surface. Why do we do that? I am going to tell you very soon. Third point is demineralization, which exposes the collagen fibers. What do all of this has to do? They are going to allow adhesive, which is bonding agent, to penetrate this exposed collagen fibers and form the hybrid layer. We all have heard about hybrid layer, right? Let us understand what it really is. Okay, so the right method to do etching, always etch beyond the bevel margin, since we don't know where the composite restoration will end. I told you this. Over etching can cause sensitivity, so specific duration. Okay, as a precautionary measure, you can add Teflon tape on the adjacent teeth to prevent accidental etching. Okay, now this picture demonstrates if this pencil marking area here is where your secondary bevel margin ends, that is where your infinity bevel is going to end. For example, you're going to still etch somewhere till over here, you know, probably 2 or 3 beyond that. So even if we have composite over there, we are good to go. It is going to bond on the tooth surface. But if you've not removed the smear layer, if it's the a prismatic enamel layer, it is not going to bond very well. And that is where your restoration is going to start coming out from. Second method of surface treatment, bonding. Let's talk about that. Bonding agent is the glue that makes composite stick firmly to the tooth. On a typhodont or anywhere, just take a small button of composite and try to place it with your instrument. You'll notice that your composite is going to stick on the composite instrument itself, and it will not stick to the tooth or the surface. Why is that so? That is because you have not added bonding agent. When you add bonding agent to any tooth surface, your composite is going to stick to that. It becomes more easy. And if it is still sticking to your composite instrument, probably you're not using the right composite instrument. Now, what does the bonding agent have? Solvents, acetone or water, and adhesive monomers. I rarely go into the theoretical part, but I'm telling you it has acetone, which is alcohol based solvent, because we need to get rid of the excess solvent. Okay, I am going to tell you how. Now, let's understand why do we do bonding. Hybrid layer formation, like we spoke earlier, resin tags, and it again, I'm going to talk about resin tags. Third point is it blocks the dentinal tubules. What is it going to do? It is going to prevent any sensitivity, right? And fourth point, obviously, is enhanced bonding again, right? Now, microabrasion, something which a lot of us, uh, never knew about. Microabrasion or agitation, you have to do that while applying the bonding agent. That is going to activate your bonding agent. What is it? You're just going to uh, you know uh, abrade or agitate the microbrush against the tooth surface with your bonding agent on it. That's it, for 10 or 15 seconds. Then you're going to gently air it out. dry to remove the excess solvent. Like I said, it's usually alcohol based, acetone based solvent. So excess solvent is going to be evaporated if you gently air dry. Okay, and what happens if the excess solvent still stays? If you don't remove it, it is going to form a bulky layer, which is not very useful for us. And instead of helping us in bonding, it is going to interfere, something which we absolutely don't want. And third point is adequate curing. We very, it's like common practice where we're like 10 सेकंड में भी हो ही जाएगा क्योर. ऐसा क्या है जो 10 सेकंड में और 10 सेकंड में हो जाएगा, right? There's a huge difference. You don't want incompletely polymerized any substance that is going to, you know, cause marginal leakage, fracture, discoloration, so many things. It's just something which you want to completely avoid. Now, let us, I just have a quick video for you guys where I'm going to demonstrate what microabrasion and gentle air drying looks like. Okay, this is the video. You take the micro brush and you rub it against the tooth surface. You're doing agitation. This is activating the monomers, which is bis GMA, right? Now, once you're doing this, you're going to air dry. Do you see the rippling effect happening? If you're not seeing it here, check it in this video. It stops eventually. See? It's not as vivid as it was earlier. Why? Because all of the excess solvent is now gone. That's it. 5 or 7 extra seconds. That's all it takes to get a more predictable result, right? So this is uh, agitation and air drying for you guys. Let's talk about the infamous hybrid layer. Hybrid layer is a zone that is formed when the adhesive resin penetrates the demineralized dentine surface or the enamel surface post etching into the exposed collagen networks. Now, do you remember when we were talking about etching? There were 2 points. One, it demineralizes the tooth structure and it exposes the collagen fibers. What is it going to do? Okay, it is going to the exposed collagen networks is going to make room for bonding agent to flow inside, and that is going to altogether create hybrid layer. What does hybrid layer do? It ensures strong adhesion, it prevents micro leakage, and it acts as a stress absorbing zone. The hybrid layer is going to act as DEJ, dentino-enamel junction, which we are going to probably break at some point. That is the shock absorbing zone. It is very important. We need to recreate that. That is going to be done only with the help of hybrid layer. What are resin tags? There was one more point at etching, that there are small microporosities which are formed, right? So that microporosities or small holes, that is where your bonding agent is going to flow, and every area where it flows into becomes a resin tag now. Resin tags are the extensions of adhesive resins that penetrate into the microporosities of etched enamel or dentine. What does it do? It creates micromechanical retention. Just visualize it, and it reduces micro leakage. If you cannot visualize it entirely, here's a diagram for you guys. What you see over here is mineralized tooth structure. After etching, this much of the tooth structure got demineralized, leading to exposure of collagen networks. Now, what happens with this exposed collagen networks? You add bonding agent. Everything in white is the bonding agent. You add that. This over here, this tiny little microporosity. So sorry for that. This tiny little microporosity is basically the resin tag which is going to be formed, right? And on top of this, we are going to have the composite resin. What is this? This acts as a stress absorbing zone. This is where micro leakage is going to stop. If there's anything happening over here, it is not going to go out. Your composite resin is secured over here. Okay, but again, most important part, You need good isolation for this. And by good isolation, I mean rubber dam and rubber dam only. So that's hybrid layer for you. I tried to make it as easy as possible. Not just the hybrid layer, probably the entire webinar. I really hope you understood most of it. If you haven't, you can obviously reach out to me. This is my Instagram handle right over here. If you do not follow me yet, please don't hesitate to follow me. You can always drop a message. You can, uh, reach out to me anywhere, anytime. And once again, thank you so much, Sudhir sir, for giving me this wonderful opportunity to share my insights today. And really glad I could do this for you guys. Thank you so much.
लॅपटॉपमध्ये कॅमेरा असतो ना
हा.
एक्स्ट्रा कशाला
Hello.
Yes, sir. I hope
Yeah.
I'm audible.
So give me 5 minutes. Yeah. There are questions, I think,
Okay.
for beginners, students, which composite kit is good to start with?
So you can, there's no specific kit. That's the whole point. You should not go for kits. Kits are going to come with only hybrid composites. I would suggest you go for individual composite syringes, or you call refills. So you can go for Tetric and Ceram 2, or you can go for Filtech Z350, like I mentioned in my webinar. So that is what you're going to go for.
3M is also good.
Yeah.
Yeah. Fine. Any more questions? Dr. John R said, thank you, sir.
Oh,
And
thank you so much.
I don't know the name. It is written only doctor. 14,
Okay.
14, he said something, I don't know. And I request
I think that was
everyone,
about the,
okay.
yes,
I request everyone, please put your names on the screen so that we can identify you. Don't write J or KJ or SK. So we are here for professional purpose. So we can identify you. And even it is important that if you're not verified and if you're not a dentist, you're not allowed to attend it. So next time, if it is there, we will remove you. And we are very strict with the protocols. Even if you are registered, you will have to write your name on the screen. So anyway, thank you, Dr. Srujan, once again for presenting it on request. Many people requested
thank you so much.
present it again. And we have next topic, I think. Give me a moment.
Yeah.
Yeah, shade selection, beveling, and surface treatment. This was the next. This is the next.
No, sir, this was the today's topic. The next is going to be
This you
probably,
covered for the anterior, like you gave the name as anterior and direct composite
yes,
restorations, but this was the coverage. This was
yeah,
covered. Okay,
yes, yes,
then same topic will be the name in next time also, but it will
yeah,
cover putty indexing and palatal uh, shelf.
and shelf, yeah. That is going to be the next
Correct?
topic. Yes,
Oh, fine. I'll do one thing in the next brochure. I'll write the heading as anterior and direct restorations and composite restorations, and in bracket I will write putty indexing and parietal shelf.
yeah, yeah,
Third will be cosmetic composite layering, and fourth will be finishing and polishing. So these are the
yes. So,
anterior topics.
yeah,
Then there are
yes,
posteriors, then there are veneers, then there are com crowns and FPDs, then there are dental photography webinars. Total 14 webinars are there for 2025 to 2026. This all I will mention in the group, and let's have more audience in future.
Yes.
Thank you, Dr. Srujan, once again. Okay. So have a nice
Thank you
Sunday.
so much. Thank you so
Have a
much.
nice
Thank you so
day
much.
to all of you. Thank you. Thanks
Thank
for
you. Thank you.
attending. Bye.
Bye.